Hey everyone, how you guys doing today? Hey Kylie, how's it going? Melanie. Are you planning on putting an ad on your videos? No, you guys already pay me to work here, so I don't want to put any other ads on there. It would be kind of unethical, I feel like. Why is it called 412 if it's 414? Because 414 is tomorrow, I think. Yeah, last time was 410. This is 412, and then we'll do 414 tomorrow, and then the review's on Thursday. Hey, Vivi. Oh, yeah, the date. Yeah, sorry. Those are the hours of the class. Yeah, my bad. Now I see what you're saying. Yeah, it's true, though. It is 414 today. And I did work yesterday in the hospital, and it turns out we all have like mandatory masking going on. So that was, my ear still hurt a little bit from having to wear the mask all day, but it was definitely necessary and good for infection control. And then we'll get started in just a few minutes. I think tomorrow you guys have your review with Professor Gerke, and then I'll be after that. But I'll be still at 2:30. If you guys have any questions from last time, if you want to just go ahead and post it up, and I'll address them when we get the video going here, the recording. What is tomorrow at 2:30? I'm doing another session tomorrow at 2:30. That'll be the end of the content. It was the earliest we can expect to see a vaccine for COVID-19 realistically. Yeah, I mean, all the estimations I ever saw were still like, 12 to 18 months out. That one's difficult because it's something that no one has really any, history with in terms of making a vaccine. It's all brand new. It makes it more difficult as compared to like H1N1 when that was a big deal. We already had a flu vaccine. It was relatively simple to add on another valence there to attack that particular strain. But yep, it'll be a while probably. All right, I'm going to go ahead and get started. So here we are today. Any questions, like I mentioned, if you want to just pop them into the chat and I'll address them as they kind of come up, and then you can still use the sticky board if anything is there. Let's see. So we were talking about our toxidromes, and we went over all of those kind of clinical syndromes you'd expect to see based off of particular exposure, right? So, for instance, if you had someone who came in and they were, tachycardic, and they were kind of altered, having hallucinations, and they had diminished or absent bowel sounds, and they were very dry, had dry mouth, you should be able to expect what kind of toxidrome might that be, and be able to assess to be like, okay, it sounds kind of like, an anticholinergic, right? Because they kind of manifest a lot of those symptoms that are pretty consistent with that, right? So if I do ask questions like that on the exam, it'll be pretty straightforward. I'm not going to give you some kind of mixed picture where I give you like a beta blocker on top of, sulfonylurea on top of X, Y, and Z. It won't be quite as difficult as that. Although that was what my boards were like. Those are pretty interesting, which I may talk about at a later date. Anyway, so getting into patient assessment. Oh, Michael, I'm so sorry about the traffic. I know it was pretty tough getting from the bed to the desk. I know I can have trouble at that too. I'm usually tripping over dinosaurs and toys and all kinds of things. But anyway, getting to the patient assessments here. Again, this is kind of getting back into what we were mentioning with our toxidromes, right? So these are things you can expect to see based on the type of drug exposure. And so again, these are all things I'm kind of looking at as a toxicologist to try to get an idea of like what kind of drug might a patient have been exposed to. So if someone's coming in bradycardic, well, if it's due to some sort of medicine or drug exposure, we know what kind of common things cause bradycardia. So things like beta blockers, obviously, things like clonidine, or maybe non-DHP calcium channel blockers, right? I wouldn't expect someone had maybe been exposed to a beta blocker to come in tachycardic. That would be very inconsistent, right? But some things that can cause tachycardia. And again, the idea here is not to memorize these entire lists specifically, but like kind of the big ones you should be able to figure out based off of like, a beta blocker, what it does. It's going to slow down heart rate, right? A sympathomimetic like cocaine or amphetamines, they're going to cause tachycardia, right? So these are kind of the things I want you to more focus on, kind of the big hit topics. Anticholinergics like your first generation antihistamines, those are going to cause tachycardia, right? In terms of hypotension, a lot of drugs can do this. Some things you would expect to see because they're cardiovascular drugs, and some things you might not expect. So for instance, like patients who have like significant iron exposure, they can get really hypotensive and acidotic, and they can be really kind of scary exposures to deal with. But even things like certain sedative hypnotics, right? So if you had someone who was exposed to like a barbiturate, or maybe someone had an anesthesia provider who had taken propofol or something, right? They could see hypotension related to that. So these are all things you'd expect to see there. In terms of hypertension, typically, a lot of sympathomimetics are going to do this. So if a patient is exposed to cocaine, or maybe they're doing meth or something like that, like, you can definitely expect their blood pressure to be up. But some things you might not expect, like for instance, if you had a patient who maybe was abusing thyroid supplements because they're using it for weight loss, for instance, right? They're taking Synthroid to help lose weight, and they become sort of this hyperthyroid kind of pictures, thyroid toxicosis. Like certainly hypertension can be on that list there. Caffeine's a big one. I'm sure many of you might be exposed to this currently, but certainly if you see patients who are taking very concentrated amounts, so for instance, things like, no dose, where they're like very compact tablets, very potent agents there, or they, have 20 Red Bulls or something. Who could say, right? Have you guys ever, I don't know if I've mentioned it before, you just mention it in the chat if I haven't, but there's a website called Death by Caffeine. That's a pretty interesting one. You can basically go in and put in your weight, put in your caffeine substance du jour, and figure out how much of it you'd actually have to consume to get a lethal dose, and you'd be surprised how much you'd actually have to get. It's amounts of coffee that no reasonable person would ever be able to ingest in a reasonable time frame. So it'd be pretty hard to do unless you got one of those kind of more potent sort of agents. Oh my goodness, I'm not even slide mode. This is terrible. In terms of temperature changes, certainly we can expect to see certain things called hypothermia, and this is frequently for agents that are things that cause you to sort of have a sedative sort of effect, or maybe things where patients are going to be sort of just like very still for long periods of time. So if you're like unconscious because of a sedative hypnotic exposure, especially if you have patients who maybe were abusing opioids and they were left outside or something, and they didn't have any, obviously not in Florida, but, say, for instance, they're up north or something like that, you can have, thermal injuries related to that as well. So that's something you can see. Not as common as hyperthermia though, because certainly we have lots of medications that can do that. So a lot of anticholinergics and some pathomimetics and even salicylates like aspirin very frequently can cause a lot of hyperthermia there. So it's a very common thing to see with a lot of anticholinergic, sympathomimetic kind of products. Getting into changes in respiratory rate, this can be a big one as well that can kind of help us out. So for instance, looking at bradypnea, things are going to have a more sedative effect. You can expect to see this. So like your sedative hypnotics. So if you had, say, like a barbiturate exposure, someone was abusing, say, large doses of benzos potentially, or opioids for sure, right? You should definitely know that one, because opioids, that's one of the kind of classic triad of symptoms of opioid exposure is respiratory depression. You can see that. But even things like clonidine can mimic the effects of opioids, and frequently they look pretty similar when they come in there, because you'll see these patients who are relatively sedate, kind of breathing's kind of shallow, blood pressure, heart rate's a little depressed, and it kind of looks like an opioid. And so interestingly enough, you can actually use naloxone or Narcan on certain clonidine exposures and actually see some good effects on their mental status. But anyway, getting to the tachypnea, this is where you can see this with things like salicylates is actually a really big one. Like, this is something I use pretty frequently to assess patients who may have had aspirin exposures. And in fact, we had one case where we actually had a patient who we suspected might have aspirin exposure, and we weren't sure if we were having significant enough effects to actually initiate treatment or not. And then we usually go by levels in those cases there. And we actually had the lab called us up and they said, yeah, we can't run the assay right now. We can't give you a level until a couple hours from now. And we needed to kind of know right then, like, is this a patient we really need to start treating or not? And based off their respiratory rate, they're so tachypnic, we ended up getting an ABG, which they still could run. And we saw they're having pretty significant respiratory alkalosis. And that gave us a sign that, yeah, there's probably enough salicylates here to warrant treatment. So we ended up go ahead and initiating the proper treatment for that patient there. But even things like cyanide, I don't know if anyone knows, but does anyone know where like a common source of cyanide exposure might be? Pop that in the chat if you have any guesses there. I'll mention that in a moment. But even like a lot of irritant gases. So for instance, if you have, I actually remember one phone call I got at the Poison Center when I was doing my fellowship, and I never had actually thought about this before, but it makes perfect sense. I'm sure some of you have been trying to clean before, maybe clean your bathroom or something, and you end up mixing something like bleach plus, say, an ammonia-based compound, and you'll see that you actually develop like a chloramine gas can develop there. It's a strong irritant. Gets in your eyes, gets in your mucous membranes, a lot of coughing, and a lot of irritant effects. And so of course that's going to cause you to have tachypnea, because you're trying to get rid of all that gas effect. And we typically tell them to go into somewhere where they can get some fresh air. But I actually had one patient call up, and he was coughing and gagging, and he was just confused as to what was going on. But he said basically he was cleaning his girlfriend's litter box. He was trying to get some brownie points, I suppose, and ended up spraying bleach product into the cat's litter box. And I don't know if you know this, but cat's urine has a lot of ammonia in it, so he ended up developing that chloramine gas and had a pretty significant effect there. So anyway, so again, these are just kind of common things that cause these typical types of vital sign changes that you should be kind of keeping in the back of your mind when you're assessing this type of patients here. In terms of meiosis, certainly we can see things like your cholinergics, clonidine, opioids, sedative hypnotics, kind of typical things you expect to cause some meiosis. Again, don't use this as your final thing to make your final diagnosis here, because like there's certain opioids you may not see those pinpoint pupils, right? And you can't really use that to rule out an exposure. In terms of mydriasis, anticholinergics, antidepressants that have anticholinergic properties, sympathomimetics, these all typically cause mydriasis. I tend to find that the anticholinergics tend to be stronger in terms of the mydriasis, because they typically are not going to be as reactive to light as they would be with the sympathomimetics. So they have this big saucer-looking pupils that are pretty pronounced when you see it. So pretty interesting kind of look to a patient there. In terms of diaphoresis, of course, anything causing hyperthermia can lead to this, so you'd expect to see your sympathomimetics and your salicylates. But also consider your cholinergic agents can do this too, right? If you recall, your dumbbells, remember that they have diaphoresis is on there, right? So, or sweating is on there. So you can end up seeing that there's going to have a lot of, just a lot of fluids going everywhere, and the skin is going to be included in that, right? In terms of dry mucous membranes, the opposite effect, right? Anticholinergics you'd expect to see there. In terms of flush skin, if they're looking very red, anticholinergics can do this, but interestingly enough, there are certain agents that can actually cause, they call it like a boiled lobster sort of appearance, and it's actually boric acid. So, some of these things are kind of esoteric, may not run into, but it's good to have in the back of your mind so that way you can identify it when it does come up. Anyway, so you see here carbon monoxide and cyanide exposures can do this as well, and that's actually where you see a lot of these exposures to both carbon monoxide and cyanides actually in house fires, and so that is something you may see, especially if you work in a burn places that have like a burn ward or say like a trauma center or something like that. You may see those patients who have been exposed to house fires coming in, and honestly, a lot of the cyanide comes from burning of like plastics and things like that, artificial fibers and things like that, and will actually develop cyanide gas, and so that's where you end up seeing those type of exposures. In terms of bullate that can form here, this is more frequently associated with patients who maybe be down for a prolonged period of time. So say they pass out and they're on the floor and they have those pressure ulcers that can that can develop and they can fill up with fluid. And that's where you see this bullate that can happen there. So not common, but something just to think about. In terms of things that can cause seizures, this list is quite large, and again, I wouldn't expect you to memorize all of these, but certainly the ones we've talked about previously that are good to know. So for instance, and here's an example of another mnemonic we like to use. This is called Otis Campbell. You can see it kind of listed out here. But the main thing to take away is there's just a ton of things that can cause potential for seizures, right? So if you had someone, say for instance, homeless patient, and they were being treated for TB, and they come in seizing, they have no previous history of it. Well, there's a lot of things that could be, right? So if they had a history of alcohol abuse, well, maybe they ran out of alcohol, right? They're having ethanol withdrawal. Maybe they were taking isoniazid and they didn't have, good stores of pyridoxine, and all of a sudden now they're having seizures due to decreased production of GABA. And so the mechanisms can change, but overall, one of the big things to note is that whenever you have a toxin-induced seizure, like benzos are the way to go, right? We're not going to use Keppra, we're not going to use phenytoin for these. You just really got to get the GABA effect back. And so that's where, lorazepam most frequently, but any of the benzos are going to be really helpful here. If that's not working, then as a backup, you can use things like propofol, for example. When I say methylxanthines, that really just includes like your caffeine and your theophylline, but caffeine obviously being the much more common thing you'd end up running into, clinically speaking. So anyway, so there's a lot of things on this list here. Some of the common ones that we kind of know about already are good to know. Again, just know the mechanisms are varied and what the treatments may be in those cases there. So, for instance, if you have an insulin overdose, and actually I just had a call about that just the other day, a patient had taken, I think a whole pin's worth of Lantus, there's like 300 units, and injected that subcutaneously. They're seizing because they're hypoglycemic, we'll give them sugar, right? So kind of look at what the obvious cause is and be able to fix that, and then you should be able to treat that seizure. Even certain odors can actually clue us into what type of exposure a patient may have had. And again, I just give this as an example here, just different things we can use to try to help us out with our diagnosis when we do have toxic exposures. So for instance, things like, mothballs, right? Mothballs have a very particular smell, maybe indicative of things like camphor, for instance, which is a common thing that can cause seizures if you did have an exposure to that. Methyl salicylate smells like wintergreen, right? So things like that. And actually, there's an interesting one here: the rotten egg smell. If you ever smell rotten eggs, it's typically due to sulfides or sulfur-based products, and that's actually going to come up in a little bit. We talk about an antidote in a few minutes. But there's a rash that's happening actually over in Japan where they were having patients who were committing suicide, and basically they were producing this hydrogen sulfide gas. And it's a very rapidly fatal agent there, but it smells like rotten eggs. And so that was one of the things when healthcare workers were going to try and save these patients there, they would start to get that smell, and that would clue them in that, hey, they probably need to stay away from this to keep them from being a potential patient as well. So you can look that up. It's kind of interesting. It's a sad thing, but certainly an interesting way these patients have decided to, kind of off themselves. This is a very good one to know. I would definitely recommend you know this for like your ER rotations or for the boards. This is your white anti-gap acidosis. You probably might have covered some of this with maybe Dr. O recently, maybe on your nephro test, perhaps. I'm not sure, but knowing your mud piles is a really good mnemonic here. And I actually like to use the cat mud piles. So it adds on a few extra things that you might want to consider there. So certainly, things like your toxic alcohols are on this list, like methanol, ethylene glycol. It's not something you see as commonly down here in warmer states, but certainly up north where it gets cold and you see a lot more radiator fluid and windshield washer fluid being used, they can see a lot more exposures there. Things like DKA, things like iron. You want to be able to kind of pick up on these and rule them out when you have a patient who comes up with a wide anion gap acidosis, right? I'm sure you guys can tell me in the chat perhaps how you actually calculate your anion gap and maybe what a normal or abnormal value is there. And again, the mechanism for this stuff can vary, but if you can try to easily rule some of these things out, it helps you to kind of clue in on your diagnosis a little easier. So for instance, if I have a patient who has a wide anion gap and I have a history they're on treatment for TB, I can look to see do they have any isoniazid and possible exposures, right? I can measure an iron level and rule that stuff out. There are things you can do, right? So if they're in DKA, obviously the sugars are going to be high. If it's normal, then it's probably not DKA, right? And then just look at the sort of where they're coming from. What was the history there? So for instance, they're coming from a house fire. Well, that makes things like cyanide and carbon monoxide much more likely to happen. So again, just a good thing to know there. I'm not seeing anything in the chat, so I'll just tell you anyway. Perhaps there's a delay, who knows? But remember, it's your positives minus your negatives from your basic metabolic panel. So your sodium minus the product or the addition of your chloride and bicarb together. And typically anything above 16 I consider to be abnormal, and that kind of leads me down that road to thinking about the mud piles here to make sure I can rule a lot of that stuff out. So we can even use some imaging studies to help us out in terms of toxic exposure. So some things are radio opaque and they can actually clue us in to an exposure. So for instance, we use the mnemonic types here where certain things will show up on x-ray. So for instance, a lot of your metals will do this, like things like heavy metals, iron can do this for sure. And again, sometimes it's helpful to make a diagnosis, but this is one of those things where if you don't see it, you can't necessarily rule things out completely. In some cases, we can even use CT scans to help us out. So if we have patients who are, say, for instance, drug mules, we can look for those drug packets there in the GI tract. Sometimes they'll show up on the x-ray, but it's not as common. But CT scan will definitely show that sort of thing there. But other things including like your phenothiazines, so a lot of your antipsychotic drugs perhaps may show up on an x-ray, enteric-coated products potentially, and then any metals are going to be radio opaque. And if you recall, even some things you might not think about, like Pepto-Bismol, right? You can see those little punctate marks everywhere because of the bismuth that will actually show up on the KUB. So a lot of different things on there that may kind of, again, clue us in and help us rule in on a diagnosis. So the next thing I want to get into is actually going to be about decontamination. And when I say decontamination, the best thing we can do for these patients is to eliminate the exposure, right? We don't want them to have any further exposure to the substance because that means that they could have more clinical effects, right? And so getting into the decontamination, there's a couple of varieties we'll talk about here. We'll talk about dermal, ocular, and then gastrointestinal. In fact, the GI ones are important because this is where, in terms of like just a pure drug exposure, you have someone who tried to overdose, this can be an important thing. But we'll look at some other ones as well. So in terms of dermal decontamination, it's always really important to make sure that the healthcare providers don't also become patients themselves. And so this is why it's really important to make sure that providers have appropriate PPE. And obviously this is a big topic nowadays because of COVID-19 and all of that. But again, you don't want the patients to be, the healthcare providers to become a new patient, right? And so this is where decon can come into play here, especially dermal decon. So once you make sure you have your people, healthcare providers, and appropriate PPE, you want to make sure that if a patient has any kind of like dermal exposure, to make sure you remove clothing first, all contaminated clothing. I've had cases where patients have, they're playing with an organophosphate or something, kids maybe, or maybe they're dealing with like cleaning solutions like, say something like Drano or something like that can be quite caustic, and they'll have a skin exposure, but they don't actually get rid of the clothes that have got the product on it too, and that continues to lead to further exposure. So that's a really important spot there. And then in terms of how we get rid of the product there, they say, dilution is the solution to pollution. So we like to flush pretty vigorously with water at a very minimum, but frequently, especially if you don't know if your product is particularly like lipophilic, maybe, water plus soap can be a really big help there. So if you got soap available, use that. Occasionally use like dilute bleach solutions as well. It can all be very useful there. And then another thing to consider, especially with patients who may be larger, if they have a lot of skin folds, make sure you go ahead and get in there as well. There's been cases where even things that might not have been all that particularly dangerous in terms of a dermal exposure, they will have like gases and things like that will get caught in these skin folds, and they'll just sit there and just eat away at that tissue. So that's a really important thing as well, to make sure they get all of that areas sort of addressed after you get your patient undressed, right? Because it's dermal decontamination. But looking at ocular decontamination, this is an important one as well, because a lot of different substances might be quite caustic to the ocular tissue here. And so we talk about time being tissue, and so this is important to get this initiated quickly. And so for one thing, if you have a patient with contact lenses in, get those out immediately, because that can be kind of a reservoir for further drug exposure, so get rid of that. And then sometimes what we have is available to us is called a Morgan's lens, and this is kind of a neat product where basically, first off, you want to make sure you anesthetize the patient's eyes, so you can use something like tetracaine potentially, and basically you're going to be hooking up to an IV set that normally has say like a liter of saline hooked up to it, and you have this little contact lens looking thing with a tube on it, and basically you place that into the patient's eye, and then this will then irrigate through with normal saline. The idea is you just kind of constantly flush that stuff out to make sure you get rid of it. And frequently here, the biggest things we worry about are going to either be acids or bases that get into the eye. So for instance, I recall one case where we had, I think, probably like a 6 or 7 year old boy. This is up in Duval County, right? So, there's parts of Duval County that's pretty country. And, these two kids were playing at home, and they didn't really have any toys available to them. And so they decided to throw around an empty bottle of Drano, tossing it back and forth. And all of a sudden the cap came off and the kids got splashed in the eye. I mean, I don't know if anyone's ever like rubbed their eye with, has some jalapeno or capsaicin on their fingers, but like it hurts. And so this stuff was pretty nasty in terms of caustic injuries. So the patients come in screaming bloody murder, can't get this Morgan lens in because he's fighting us so hard. But we got to do it, right? Because time is tissue. And so we ended up eventually giving that kid some ketamine just to just knock him out. He was chilled out finally. We can get the Morgan lens in and then flush that eye out. It's really important whenever you have these caustic exposures, make sure you get back to a normal somewhat pH for the eye, which is typically around 7.2 or so. It would be fine in those cases there. That's a big thing, but really 15 to 30 minutes of flushing is important. If you did have something like a Morgan lens, sometimes what we'll do, especially with like EMS outside of the hospitals, you can actually take a nasal cannula, hook that up to a liter of saline, and just put that over the bridge of the nose, and that way it'll just kind of run into the eyes. And again, you want to run away from the eyes themselves, so kind of make sure it's going in the right direction in those cases. So getting into the GI decontamination, next we have a couple different agents here, most of which I'm going to tell you not to ever use, some of which are not actually available any further, but still important to know about, so you can at least talk about them, because patients still think we do a lot of this stuff, even though we really don't. The first one being syrup of ipecac, and so this is actually something you can really only find as like a very dilute, like homeopathic substance, but it used to be kind of just the most common thing we'd use for GI decontamination. So Kylie says, how do you prevent the Morgan's lens flush acid base into the nose or the mouth? Typically with the patients being laid, it kind of flows in the direction outside of the eye. So you'll typically find that's not usually a concern. Just with the way that the face is kind of oriented, patients are laying back, it'll flow in the right direction. And again, you're using a ton of saline to flush through the eyes here, so it's going to be something where it'll be diluted out, so we typically don't see a lot of other injury to the skin potentially. That's a good question. But yeah, patients should be lying back for that procedure. So anyway, so getting a syrup of ipecac, basically this is a product that directly stimulates the chemoreceptor trigger zone, and so causes very severe emesis, as you can see in this picture here. This is, I don't know if anyone's ever seen this clip from Family Guy, but it's quite funny. The issue with it is that in a lot of cases you'd actually find that it's not all that effective, and especially with GI decontamination, kind of the golden rule is you need to get things done within an hour after the ingestion. If you can't get there within the hour, for the most part, most of it goes past the pylorus of the stomach, and you're not really going to get a whole lot of benefit there. And so in this case here, with ipecac, we would see that the problem is that we wouldn't really get a whole lot of return on investment, so to speak, in terms of getting the drug out, or whatever the substance was. And not only that, but also then you have to worry about patients aspirating, right? And so if you get all that GI content down into the lungs, that can be worse than the substance they might have gotten already, right? And so the other big concern was the fact that this was a common agent used by patients with bulimia who are trying to induce emesis in order to lose weight. And what they actually found is that it can cause cardiomyopathy. So you'd have these relatively young, thin patients who are coming in complaining of like maybe dyspnea and exertion and just fatigue and all these things, and you do an x-ray and you saw this huge heart and you're like, well, how did this happen? And then you go down and get the history and it's like, okay, wow, they've been abusing this stuff for a while. And so because of that, they basically removed it from the market. And so if you do see it, it's probably like a homeopathic product, but it's not really going to do the same thing as like a true syrup of ipecac product there. I think in my tox memorabilia, I have a bottle thing that expired back in '85, but I have not tried it, and nor will I try it. The next thing here is gastric lavage. This is something you frequently will not do unless it is a life-threatening ingestion. And the other big thing too is that you have to be within an hour of exposure. And so frequently you either get patients that are presenting too late, or maybe don't know the time of exposure. So if a patient maybe was exposed to an opioid and they're unconscious and they can't tell me when it happened, then I can't necessarily assume it was within the hour. And so we frequently, due to the complications of these procedures, we will just go ahead and skip it in a lot of cases. Let's see, Sarah had another Morgan Lynn's question. Can you only use it if you're sure there aren't any particles in the eye? Do you have to pick a quick flush first before applying? Most of those patients will probably have had some degree of flushing beforehand as you're getting the Morgan Lynn set up. So not necessarily. I mean, this thing is flushing a lot of fluid through, so I've not seen any issues with like corneal abrasions or anything with particles that get stuck in there, just because you are flushing just a ton of water straight through that thing there. So I'm not aware of any issues that have come up from using that. So anyway, with the gastric lavage, typically what we're doing is we will go ahead and place an NG tube into the patient, and then you can see this device here. Basically, you're going to be flushing in either tap water or in some cases things like normal saline into the patient. And then basically, and I wish I had a picture of the tube itself, but there's tiny holes that are going to be placed throughout the NG tube. That the idea is you flush all this fluid into the stomach and then you suck it back out. And the idea is you're going to get all that drug back out, and then you can eliminate it, right? So that way you kind of eliminate the exposure. Problem is that you're going to find these patients, one, are going to be presenting too late, so you can't really use it. The other thing, too, is that the holes are not really going to be good for a lot of products to fit through, right? The holes are going to be such that maybe like a small tablet, like maybe a digoxin or something, can get through. But like if you have like a big iron tablet, or if you have like a big lithium tablet or something like that, there's no way it's going to get through there. So again, you have limited efficacy for this, but maybe if I had a patient who like had just ingested like a ton of a toxic alcohol or something, and I knew it was there in the stomach, maybe do it. But for the most part, I really don't recommend this to patients, or recommend this to providers to do for patients. Typically, we'll put them on their left lateral decubitus position because this helps to prevent elimination of contents to the stomach to some degree. It helps, but that's what we're going to do there. And again, if patients are at risk for aspiration, normally we're just not going to do this. So unless they have their airway secure, or they can secure their airway, this is something we don't necessarily initiate very frequently. But again, you always like talk to patients and they're like, oh no, they call the poison center, like, oh, they have to go pump my stomach. That's what they're talking about, and oftentimes we don't, because again, the aspiration risk is an issue. But here's some other things that are going to be contraindications to using it. So for instance, if it's a foreign body that could be an aspiration risk, don't do it, right? Because again, I'm more worried about the airway obstruction than I am about probably the product in the GI tract. Any kind of corrosive substances, acids and bases, if they burn on the way down, they're going to potentially burn on the way back up if the patient vomits. And so typically this is going to be a contraindication for lavage. And this will come up again when we look at some of the other GI decontaminants. Hydrocarbons as well. If you had something like, say, kerosene or some kind of like gasoline or something like that, they frequently as well can be an issue if you were to aspirate them and cause pretty significant pneumonitis. So we don't do that. And as mentioned, if the toxin's bigger than the lavage tube hole, there's no way you're going to be able to get that pull through. So it's just not going to be all that effective there. And again, some other complications, including the aspiration, is especially if they've had, say, like a caustic injury, pretty strong caustic injury, you could see esophageal perforation. So again, another reason why this would be contraindicated for those corrosive ingestions. So the one thing we do recommend with some regularity is actually going to be activated charcoal. And so again, this is going to be within 1 hour of ingestion. And actually, if you have something that's slowing down the GI tract, like an opioid or an anticholinergic, we'll give them up to 2 hours potentially. So if I have that history, if I've had someone who had ingested a bunch of, say, Tylenol PM, right? So it has Benadryl or diphenhydramine plus acetaminophen. That's something I could do within 2 hours, right? For most other things, though, it's going to be 1 hour. And the idea is with this activated charcoal, basically it's treated to extremely high heat and pressure that causes the surface area to be huge. I think like a bottle of this stuff has like the surface area of a football field. And the idea is it's going to bind up to all the medications or substances that might be in the GI tract and prevent it from being absorbed, and then it'll be just eliminated in the feces here. And so it absorbs a lot of toxins, and so it's pretty has wide applications for a lot of different substances there. And you can see typical dosing we do between 25 and 50 grams, or about 1 gram per kilo in peds. And again, I'm not going to ask you dosing on the test, but just for reference's sake. So the important thing to know about activated charcoal is what it does not bind to. So for instance here, you're going to see that metals is going to be something that charcoal just doesn't work on, right? So if I have someone who came in for an iron ingestion, say they took a whole bunch of prenatal vitamins, this is not going to be all that effective, right? Lithium, hydrocarbons, alcohol is another important thing. Frequently, alcohols, because they're liquid, are going to get past through the pylorus of the stomach so quickly. Anyway, it's difficult for charcoal to catch up, but also just doesn't bind to it as well. However, if I had a mixed ingestion, let's say someone had bipolar disorder and depression, and they took a whole bunch of their TCAs and lithium, well, while that charcoal might not bind to the lithium, I can give it for the TCA potentially. So you still may see it used for mixed ingestions there. In terms of contraindications, a big thing to watch out for is going to be for aspiration risk, right? So if there's a foreign body, if it is a corrosive substance, anything like that, you don't want to use this because, again, they aspirate to the respiratory tract. It's not going to be great things there, okay? And then any intestinal obstruction, obviously charcoal is not going to be able to pass through, and so that could cause further obstruction. So that's a relative contraindication there. Last thing here is going to be Holdout irrigation that we can do. And so this is basically where instead of trying to bind up the drug or trying to prevent the absorption here, in this case, we just want to flush everything through as quickly as possible to try to prevent it from being absorbed. And so we'll do this with polyethylene glycol or Go Lightly solutions. And, like the same thing we'd use for like a bowel prep or something. And we want to flush the entire GI tract out. And so you can see here the rates we're giving between 500 mLs an hour to start with up to 2 liters an hour. And so while some patients may be able to drink this, it is very unlikely they're going to be able to. If you recall, I mentioned that Go Lightly kind of tastes like warm sweat because it's room temperature. It has a bunch of electrolytes in it, so it's kind of salty tasting. It's not great, and so to expect someone to drink anything at 2 liters an hour rate would be quite difficult, right? So frequently we're putting an NG tube down the patient, and we're going and running this on a pump. And again, 2 liters an hour is a lot, so again, you're going to expect a lot of bloating. You can expect to see potential for vomiting, so again, you want to make sure you treat for that as well. And our goal is to make sure we have clear rectal effluent, right? So that sounds pretty descriptive there, but the idea is we want to flush everything through, make sure it's coming out clear, then we know, we've gotten everything that we can. And so the other big thing to make sure is you got to make sure we can get that NG tube placed. You got to confirm placement of the tube, so make sure you can hear bubbles in the stomach and things like that if you're pushing air through, because if you Go Lightly into the lungs, that's not great. You're going to cause pretty significant pneumonitis and bad effects. So what is this good for? This is typically good for stuff that maybe charcoal is not great for. So heavy metals, for sustained release products, and maybe able to absorb throughout the entire GI tract. Or potentially we can use it for body packers and stuffers. And so I've kind of alluded to the body packers before. Body packers are typically people that are like drug mules, or they're going on a trip somewhere and they have large amounts of product that are pretty well wrapped in a lot of cases. Body stuffers are typically people that are going to be, say for instance, like you're a drug dealer, you're on the street, and all of a sudden you see some red and blue lights. You're worried about getting arrested and being caught with all this drug product on you, and so maybe you just go ahead and swallow it, right? So it's typically smaller amounts, but maybe they're not quite as well wrapped, and maybe it's in some plastic wrap or something like that can open up and then can be absorbed. So stuff like cocaine in the GI tract is not great because it causes a lot of vasoconstriction and can lead to mesenteric ischemia and death, right? So in those cases where we have body packers and stuffers, we can use Go Lightly to go ahead and flush all that stuff through. And so, as I mentioned, these are what it's used for. Sometimes we'll actually do charcoal followed by the Go Lightly, so that's good for like mixed ingestions. We call it Go Darkly at that point, and you can also use the charcoal. It's kind of like a tracer, so you kind of know how far we've kind of working everything through the GI tract when the patient is on that bedside commode. So something I don't recommend frequently because it's pretty difficult to do, and it kind of requires one-on-one nursing to patient ratio, and that's hard in any situation, whether it be in the ICU or in the ED for sure. So one product I wanted to talk about here in more detail is actually going to be acetaminophen. And so I talk about this mainly because it's such a ubiquitous product. You're going to find it everywhere. I can go to Costco or Walmart or anywhere and buy just huge amounts of it. Most people have it in their homes, and as such, it is a frequent ingestion. You see, for intentional harm, maybe for accidental harm. Say if someone has a lot of pain issues and they don't realize how much they're taking, or maybe they're taking this in conjunction with other products like Percocet or Lortab or something like that. And so the other big problem with acetaminophen we're going to find is it doesn't really have a clear defined toxidrome. You can have patients who have had massive ingestions of acetaminophen who are asymptomatic for hours, maybe even a day. And so this makes it a pretty difficult clinical sort of issue. So just to make sure you guys aren't completely bored, I wanted to really spice up the lecture here by going over the biochemical transformation of acetaminophen in the body. And so basically here we're starting out with acetaminophen, right? So how does it get eliminated through the body? And so most of the time you're going to see they can go through some of these conjugation pathways. So some of it gets eliminated unchanged. Some of it gets this glucuronide conjugation. Some of it goes to the sulfation pathway, and this is the majority of it. And these are safe byproducts that your body can just eliminate no problem. Well, what happens when you have say a massive ingestion? Let's say you overwhelm these pathways. What happens here? Well, basically by overwhelming that, you're going to get a larger percentage of this going through this other pathway here, the CYP enzyme pathway. It's actually CYP2E1, and it's going to cause this formation of this product called NAPK. Now, normally NAPK is not going to be a big problem, mainly because we have the ability to glutathione conjugate that into a non-toxic product here, right? So this is not a big deal under normal circumstances. When you have really big ingestions here, you're going to find that you're going to overwhelm this. You're going to form a lot of NAPK, and this is what leads to that hepatic injury, right? So we've talked about, Tylenol is bad on the liver. This is why. It's because you have this NAPK formation here. But it's not just bad on the liver. It's going to be bad on the kidneys. It's bad on the heart. It's bad on a lot of things. And so these patients have really massive ingestions of the Tylenol. They can get really, really sick. The question is, when is that going to happen? And so, again, looking at levels here, you can see that, a typical therapeutic dose is between like 10 to 15 mg per kilo for a patient here. And these patients, they get above levels of, say, 150 to 200. This is where they can get into trouble. So it's, not that much more than what a typical therapeutic dose is. It's quite easy for patients to get a toxic amount potentially. 5-6 grams can be enough to be an issue for some patients, right? So anyway, as I mentioned, the NAPK forms those covalent bonds. It causes a lot of cellular death. It also forms a lot of free radicals, so you get a lot of oxidative damage that happens here. And as I mentioned, it's not just the liver that takes a hit, but it's a lot of other organ systems as well that we worry about. So, and some patients tend to be more likely to become toxic than others. So for instance, if they have, say, they're taking many frequent doses over the course of a long period of time, they can have that kind of chronic sort of ingestion where they're kind of, it's more of an insidious sort of presentation there. If they are chronic alcoholics, this can be an issue because you'll find that alcohol actually upregulates CYP2E1, so they're just producing more of that enzyme, meaning they're more likely to form more of that NAPK. And then if they have reduced glutathione stores, they also tend to be at risk because they will not be able to go through those safe sort of metabolic pathways. So, and I kind of want to work you through a few stages here because this is really important to understand, and I find a lot of providers don't really know this as intrinsically as I do, and that's okay because that's why they call it the poison center, right? But the thing you have to understand is that Tylenol doesn't really present with a lot of signs and symptoms until like 24, 36 hours out. So kind of walk you through the few steps here. First, stage 1, typically the first 24 hours, no hepatic injury is seen. You can check LFTs, typically don't find anything going on, right? Patients most likely are asymptomatic, but if they really do have large ingestions, sometimes you have maybe some nausea, vomiting, some malaise, but really kind of non-specific symptoms here. Very rarely will they come in with loss of consciousness and a metabolic acidosis. I've very rarely ever seen this. But where it gets more tricky is when you get into like this 24, 36 hour kind of time frame. This is where you're going to start to see your transaminases are elevating, so you're going to see AST, ALT start to rise. And the other really big thing I worry about as well, because they call them liver function tests, but really looking at AST, ALT doesn't really tell me how well the liver is functioning. What I look at is usually going to be things like bilirubin and PT-INR. It's telling me how well is the liver actually doing its job there. And if I start to see PT-INR going up, I know the liver's not producing those clotting factors like it should. And you can also look at things like lactate as well to help you out. And so these will be sort of a later thing that normally show up with like really large ingestions, but they could show up as early as that 24 to 36 hour mark. And then the stage 3, this is where patients that they're going to die most frequently do. The 3 to 5 day sort of mark here, but this is where they're going to have further increases in transaminases. They can get up into the several tens of thousands potentially. They'll have jaundice. This is where they can get some of the other bad effects from the Tylenol, like the renal failure, cardiac toxicity, altered mental status from the encephalopathy of the due to the liver dysfunction you're seeing there. Pretty nasty stuff. And this time, it can be kind of hit or miss whether or not these patients are going to be able to actually recover from this. So it could be pretty dangerous. I'll give you a good clinical scenario here in just a few minutes. Yeah, hopefully they'll make it to stage 4 where they can recover, and then you may find that it takes weeks to months for that to have complete resolution. But the liver is a pretty amazing organ that's able to repair itself, and so we'll find they will have complete resolution at some point. But some cases they actually do require liver transplant, even though it's not common, but you can see it potentially. So with these patients here, this is why, again, whenever you have a potential drug exposure, you always check a Tylenol level. You always do it, just because this patients will be asymptomatic in many cases. So they're asking, are there any commonly taken medications or substances that cause 2E1 induction? Mostly alcohol is probably the most common one there. There are a few others. So I believe you have patients on isoniazid that can do it as well. That can predispose them, but alcohol is probably the most common one you end up seeing there. So anyway, as I mentioned, the history is often unreliable. So that's why you always check a Tylenol level. So if you ever see like a tox workup, always get a APAP level. In terms of the amount ingested, you can see here even doses above 7.5 grams as a single ingestion for an adult can be enough to be toxic. And then for kids, between 150 and 200 mg per kilo is usually when we'll consider sending them in to get further evaluation. And what we do here is we use what we call the Rumack-Matthew nomogram. And so this is a pretty commonly used nomogram. You'll probably see it maybe somewhere on their boards, or if you do like your ER rotation, something like that, you'll run into this. And this is the nomogram we use to determine how likely patients are going to develop hepatic toxicity from their Tylenol exposure. And so I don't know if you guys ever will get the chance to meet one of your clinical heroes, but I actually got to meet Dr. Rumack at a conference one time. Dr. Matthew had actually been dead for several years at that point, but it was like meeting a rock star for the first time. So it probably says more about me than anything else. But anyway, so the point here being is that this is a nomogram where you can chart the patient's Tylenol level, and based on where they show up on this line, you can determine whether or not you need to start treatment. And we'll talk about the antidote here in just a few minutes. And the typical thing you think about is that at a level of 150 micrograms per ml at 4 hours, anything above that you would consider to be treatment. You want to go ahead and start the antidote. If it's, say, 4 hours post-ingestion and say it's 100, then you don't have to do anything. The level's elevated for sure, but they're not going to be at risk or a very significant risk for hepatic injury. You're good to go. You don't have to do anything. But let's say they come in and it's 8 hours past the ingestion, right? So look at this. Well, you see, okay, if it's above 75, then yeah, they're probably going to need to go ahead and treat anyway. So again, plotting out where the ingestion happened, where their level is at, and seeing if they're above this line. If they're above it, you treat. Okay, it's pretty straightforward. The issues come in, though, is when you don't know when the patient might have ingested it. That can be troubling. If you have no idea whatsoever, typically patient or providers are more conservative and they just go ahead and treat anyway. So we tend to over-treat rather than under, because it could be really significant and kind of late presenting when these patients do become symptomatic. So that's pretty straightforward. Let me know if that doesn't make good sense. We can go over it again. And again, when we're monitoring these patients, Tylenol levels, LFTs, we're monitoring for PT-INR is another thing there. And actually, what's interesting is that I have some providers who will just go off of the Tylenol level. And so sometimes what we'll have is we'll actually have patients who will show up presenting very late. Like, say, for instance, they were to ingest a huge amount of Tylenol on Monday morning, and then Tuesday morning they're like, oh man, I really shouldn't have done that. I'm starting to feel kind of weird, and they go into the ER and tell them what they did. That Tylenol level might be negative at that point, but their LFTs are starting to rise. Okay, remember, it's not the Tylenol itself that's doing the damage; it's that NAPQ metabolite. So I'll have some providers will say, well, the Tylenol level is negative, I don't have to do anything. It's like, no, their LFTs are in the hundreds, several hundreds, maybe 1,000. You got to still treat. And so we'll talk about some of the other finer points of that in a few minutes. For more significant ingestions, check a PT-INR, especially if the LFT is already starting to rise. And then BMP is helpful to tell me kind of what if there's any kind of acid-based disorders kind of going on. Make sure electrolytes and all that are good. Keep in mind too that glucose could become an issue as well, because where do we produce a lot of our glucose for blood sugar? From the liver, right? So you can see where that can be an issue. So anyway, in terms of management, obviously start off with the ABCs for these patients here. In terms of GI decontamination, if it's within the hour, go ahead and give that activated charcoal. That can maybe potentially prevent a toxic amount of Tylenol and absorb a lot of it, so that way the level never really gets to a point where you have to actually end up treating it. If it's something where it's like Tylenol plus diphenhydramine, or say Tylenol plus an opioid, then maybe you have up to 2 hours. I would go ahead and recommend it at that point as well. To get hypoglycemic, you give them sugar, right? I probably wouldn't give them glucagon, mainly because you're trying to stimulate the liver to produce glucose, and if they're hypoglycemic due to this, their liver is probably not in a state where it's going to be able to really help out very much. And in terms of coagulopathy, we can give vitamin K, but obviously the liver is not really doing its job, so there's limited capability for this to really help. In rare cases, do we need blood products? But that's something, you consider on a case-by-case basis. And then there's what we call the King's criteria in terms of determining if a patient is going to be a candidate for transplant. And I wouldn't memorize these here, but just know that there are certain things we're looking for to determine, is this a good candidate who is severely sick enough where their liver is unlikely to recover on its own, and we want to go ahead and give them a new one potentially. So this is very uncommon we do this, but there's been some cases I've encountered where patients have had accidental ingestions, maybe over a long period of time. If it's an intentional ingestion, that's a harder sell, but it just depends on a case-by-case basis. So what can we do to treat this, right? How do we deal with this? Well, basically what we can do is we can replace what the liver's missing to help metabolize off all these products here. So as I mentioned, these systems get overwhelmed when you have a massive ingestion, and this system here gets overwhelmed with glutathione conjugation. Well, what if I could replace some of those cofactors? And so this is where NAC comes into play. NAC stands for N-acetylcysteine. You can see a few places here where, one, it's helping to provide the necessary molecules to do sulfation, right? So you can see it there. And then it also helps out with this glutathione conjugation as well. So kind of two main ways that this helps. NAC is also a nice free radical scavenger. It's an antioxidant. And so this can actually help to deal with a lot of those kind of extra hepatic sort of effects you can see as well. So as I mentioned, it's a glutathione precursor. It can donate sulfhydryl groups, and it helps to substitute for that glutathione. So it helps in a lot of those different metabolic pathways there. The nice thing about N-acetylcysteine is that if it's given within 8 hours of the ingestion, it's like 100% effective in preventing the need for liver transplant and death, right? So it's very, very effective. The problem is when patients show up after 8 hours of ingestion, but in a lot of cases, we'll still give it even after that time frame because of that free radical scavenging. We actually do see some mortality benefits when we give it later. So, and the interesting thing about NAC as well is that it actually, because of all those sulfhydryl groups, all that sulfur, it actually smells like rotten eggs. So that'll be important when we talk about administration in just a few minutes here. The one thing I forgot to mention with the Rumac Matthew nomogram too is that keep in mind it starts at 4 hours, so you can get a level beforehand, but you can't plot it on the nomogram. This is the only way it's been validated, so this is an important feature here. If you get an hour or a levels at 2 hours, you got to repeat it at 4 hours. So make sure you mark that down, because I see a lot of providers who will try to plot it. A level is done at like 1 hour, 2 hours post ingestion. It just doesn't work that way. Okay. So anyways, we talked about NAC, getting into how we give it. There's two different varieties. There's the oral N-acetylcysteine, which is known as Mucomist, and then there's the IV form called acetadote. The main difference is between cost and in terms of efficacy, they're equal, right? So that's the nice thing there, and they're both very, very safe products. There's two ways we can give it. There's the IV way we can do it, which is a 21-hour protocol. And again, don't memorize the dosing here. I'm just kind of giving you this to illustrate it. And then there's the PO protocol. And so you can see here that this is a 72-hour protocol you're doing there. So you're treating for a lot longer, but this is the way we did it for a long time just because that's all we had, right? And so some providers like this better, the IV one, because it's only 21 hours and you're kind of done at that point. So that's one thing in its favor there, but it is more expensive, and there's some other issues with it as well, which I'm not going to delve too much into. But the problem with giving it as a PO is because of all that sulfur that's in it and it smells like rotten eggs, patients are less likely to take this, especially if they're trying to harm themselves and they're not really all that willing to go along with treatment anyway. And that stuff smells like rotten eggs and they're going to want to vomit, and so then you got to give them some Zofran for that, and then they may not really take the whole dose, and there's a lot of issues with it. So for the most part, I try to shy patients or providers to try to get them to use the IV therapy because it's just easier that way. I will tell you, my first day working in a hospital pharmacy as an intern, we also, if you recall back to our talks of CF, we used Mucomist as a mucolytic, if you recall, as an inhaled product that you can nebulize it. You can use it for that. Well, my first job as an intern when I was in pharmacy school at the hospital is they said, okay, here's a big vial of N-acetylcysteine, and you got to take up and put it into little bottles so that way we can use it for our neb. So there's like a big 30 ml vial, and I was putting it into little 3 ml aliquots here for the respiratory techs to use, right? And so I got to sit there and smell rotten eggs for my first week working there, and that was basically the point where I got desensitized to it, and now it just smells like regular eggs to me. So I don't know, it is what it is. But stuff smells rotten. If you ever get a chance to smell it, I would try it out because it's interesting. You're right. So that's kind of. Oh, and the other point there is if our protocols are inadequate, if we have patients who are still having issues and their LFTs are still high and Tylenols are still positive at the end of these protocols, we just continue giving more. So I'll give you an idea of a good case I had one time. I had a patient who he was, I think it was a graphic designer, but he lost his job, had 2 kids, a wife, and he was really worried about not being able to provide for them. So he said, he's depressed, so I'm just going to end it all, right? So he goes and takes a huge amount of acetaminophen, just a massive amount. He says, all right, I'm going to go to sleep, and that'll be it. I'll die in my sleep, and everything will be over. Guy wakes up the next morning. He's like, wow, I survived. Everything must be good, right? Well, not really, because now you know that it takes time for Tylenol toxicity to occur. And so it wasn't until later that day they actually went over to the library. He's looking it up. He's like, well, what happened here? Why didn't I die? And he was looking at it and he's like, oh, this doesn't show up until 24 hours later. So he didn't actually come up to the ER until he was already, I've never seen one jaundice as this gentleman was in my entire life, just yellow from head to toe, looked like he was just covered in mustard practically. And so he was already having significant bumps in his LFTs. His LFTs were in the tens of thousands. His INR was already starting to bump, and he was very, very sick. The problem is he was presenting way after that 8-hour mark. And so at that point, too, we didn't even care what his Tylenol level was. We knew he needed an N-acetylcysteine. So we started the protocol, and I think he ended up being on 4 days worth of the IV therapy, 4 or 5 days worth, before we started to see resolution of his LFTs. Started to come back down. PTIR started to normalize out, and he ultimately ended up surviving. And that was very kind of hit or miss there for a while. He's in the ICU for quite a period of time there. So he ended up doing okay, just showing you how well the liver can recover itself. But it's one of those things where, again, you got to check it for every intentional ingestion, because if you miss it and those patients come back 24 hours later, that can be a problem. It can be kind of playing catch up with your antidote there. So that's it for acetaminophen. I don't know if you have any questions. I'll look on the board here. I have a few sticky notes. Let's see. Weird question, but I remember reading something that in ancient times, wealthy people would drink a tea to make themselves vomit after a fancy meal so they continue eating. Any links to Ipecac, GI decontamination? This is probably something similar to that. The syrup of Ipecac actually comes from a plant-based product. It's called the Ipecacuana plant, I believe. And so that would make sense if they were using something similar to that. So you could definitely brew that into a tea. I don't know if it's that specific product, but yes. So I would not recommend doing that. I think you may have an eating disorder if you're doing that. So I would recommend against it. Let's see. How to decontaminate compounds that can react with water, like sodium. That's interesting, because it probably would have reacted with the patient's skin already. I guess ideally you just use a ton of water. We're using just gallons of stuff to flush these patients here, especially if you're in a mass casualty event or something where you're having to just use a ton of water anyway for biochemical exposures or something like that. So yeah, I've never run into specifically like just the sodium metal itself, but typically, even if you would imagine, trying to think other cases, because one of the things people try is, especially if you consider like you had a caustic ingestion. So say someone drank some hydrochloric acid or something like that, right? Or bleach, for instance, something like that. Some providers will try to neutralize it or say, okay, well, if they drank a base, I'm going to give them an acid and that'll neutralize it out. Or if they had an acid, I'm going to give them sodium bicarb and that'll neutralize it out. We don't like to do that because, one, what happens when you neutralize an acid or a base? Well, you produce gas and you produce heat, right? So not only do you have that caustic injury going on, but now you have all this extra gas being produced here, which can cause distension, which can cause damage to that tissue further, can lead to perforations, and that heat can also lead to thermal injuries. So the idea in those cases there is just dilute it out, right? So we go ahead and just make sure we're using a ton of dilution and try to prevent any further injury from happening in those cases there. So on the skin, that would be no different in those cases. So just out of curiosity, if a patient took a drug that can cause the opposite effect, such as meiosis and mydriasis, does the effect cancel each other out? That's a good question, and it depends. So you'll find that depending on the situation, maybe they took more of one particular drug than another. So you may find that one is more predominant. So for instance, if someone took, say, a bunch of diphenhydramine and an opioid, right? So they took, maybe Percocet or something along with diphenhydramine. Diphenhydramine should cause mydriasis because it's an anticholinergic. Opioid should cause meiosis. And so you may find that the anticholinergic properties are more predominant, and then you would see the mydriasis. I don't think you really get kind of a balancing out effect where they would be kind of normal range, normal sized pupils. But you may find that, especially over time too, it may evolve. So they may come in very mydriatic at first, but then they come in more meiotic later on, right? So it depends on the situation there. An interesting case would be like the organophosphates, where there was exposures, and it's kind of interesting. There was back in Japan, I think this was in the 90s at some point, maybe late 80s. There was a kind of this like death cult where basically they were trying to commit a terrorist attack, and they actually released sarin gas on a Japanese subway. And so sarin gas is an acetylcholinesterase inhibitor. It's not an organophosphate, but it's one of those nerve agents. And so what's interesting is you actually see the nicotinic effects present early, and then the cholinergic or the muscarinic effects then predominate later on. So these patients actually show up, and if you recall, that mnemonic we use for nicotinic effects was the days of the week. Well, the M was mydriasis. So these patients were showing up, and even though it was an acetylcholinesterase inhibitor, they were presenting initially those nicotinic symptoms. They were mydriatic at first, and then as the muscarinic effects took over, they became meiotic. So things evolve over time too. So it always comes down to it depends is my answer to most things. So see, any other questions on that stuff? I see nothing in the chat, so I'm assuming I've answered all of your questions to sufficient abilities. Let me see. Let's see how many slides I have left here. I have a decent amount of slides. I'm going to talk about snakes now, if you guys don't mind. So I'll talk about snakes first, and then we'll come back tomorrow and probably finish off with our marine envenomations and some other creepy crawlies and stuff like that. So if you don't like pictures of snakes or spiders and things like that, this might not be the best section for you. But guess what? We live in Florida, and you're going to see a lot of this stuff. So this is why we talk about it for sure. Okay, so let's get into envenomations. I like to talk about snakes. I do enjoy a good snake bite in terms of treatment. Pretty fun. Not great for the patient though, so that I don't suggest people go out and get bitten by snakes on purpose. But anyway, getting into common venomous Florida snakes. So we're going to have two main varieties. We're going to have what we call the Crotalidae, or the pit vipers, and then we're going to have the Elapidae, or the coral snakes. So those are the kind of two big delineations. The reason why I make that delineation is mainly because they have very different toxins, and so they present very differently from one another. So to get into the Crotalidae first, we're going to talk about those, and then we'll get into the Elapidae second. And so you can see the list here in terms of the common Florida snakes. We have the copperheads, we're going to have cottonmouths. I'll show you some pictures in a moment. Also the pygmy rattlesnakes, and then some eastern diamondbacks. There's a few other ones, some around here and there. And keep in mind, people in Florida, the laws to keep exotic animals. I don't know if you've watched Tiger King by any chance. But owning exotic animals is surprisingly easy, and so we have snake handlers that will be, keeping private pets that are, black mambas and green mambas and all kinds of Egyptian cobras and all kind of things like that. And actually, I would recommend, once we are back open and the country's open, you can do this. There is a serpentarium in St. Cloud. I would suggest checking out if you're into snakes, because they have a lot of really cool stuff there. And I can give you more information later if you like. I have no financial ties with them, although I would love to. That guy's just fascinating. Very good chance to talk to him. But he's been bitten by so many snakes. He's missing a few fingers from some of his envenomations. But anyway, getting into the epidemiology, we typically see, because reptiles are cold-blooded animals, they are more active during the warmer months. So most of the bites happen between May and October, although I've seen snake bites that happen in December in some cases there. So it just depends on how active the snakes are. And we typically see that the frequent victims are going to be either handlers and collectors. Obviously, because if you're around the snakes, you're more likely to get exposed to them and have a bite. Kids, because they may see something colorful on the ground, they may be running around outside, they are more likely to get it. And then, unfortunately, this is a disease of the Y chromosome, as it turns out. Why, you may ask? Well, I don't know if you are aware, but testosterone does make you do some pretty silly things. And so, interestingly enough, if you look, again, this is more epidemiology for the U.S. here. If you see a snake on the ground, I don't know that, a lot of people would say, let me go pick that up. But if you have, for instance, alcohol involved, or you want to take like a selfie with the snake, this is where we see some of these bites here. And a lot of this stuff sounds incredibly stupid, and it absolutely is. But again, this is what keeps me in business. So, I'm not gonna tell them to stop necessarily. So anyways, we see that a lot. And actually, what's interesting is if you go into other, maybe like underdeveloped countries, you go into other places where you have a lot more like, farming and things like that, where a lot of like cobras and whatnot are more present. You actually find that the split between males and females and adults is actually pretty equal, because both of them are out there potentially being exposed. But here in the U.S., it's usually males who are like handling the snakes and picking them up. So anyway, so first off here, we have our pygmy rattlesnake. And so some of the things I want you to kind of focus in on are going to be how we identify whether a snake is venomous or not here in Florida. So we'll talk about some of the common features here. So one of the things you can already notice is they have a rattle on the tail. That's not always there, especially after they shed recently, but that's something we look for. They also are going to have a big triangular head. And so this is for the Cortalidae specifically. These are called pit vipers. So a big triangle head is also going to be another clue that we're dealing with one of these. Here is a copperhead. These are actually kind of the weaker of the bunch. You're going to see these are kind of wimpy in terms of envenomation as compared to some of the other ones. Pygmy rattlesnakes tend to be a little bit worse than these guys. You have the water moccasin, or the cottonmouth. Obviously, you can see why we call them a cottonmouth. You can notice a big white mouth here. But again, you can't always go off the coloring of the snake. You can't just say, oh, it was a black snake. There's a lot of black snakes out there that are non-venomous, but we'll look at some other common physical features there. And then we have the eastern diamondback. These guys can be really, really nasty in terms of envenomation, and can be quite difficult to treat. They pack a pretty hefty punch. These are quite large snakes, as you see. So how do we identify these? Basically, they're called pit vipers because they have these heat-sensing pits, and this is how they actually kind of track their prey. They can actually detect minute changes in temperature and be able to get whatever animal they're going after, for instance. They will also have large hinged fangs. That's basically like two hypodermic needles that they can use to inject their venom into their prey. And then we'll also talk about a few other things here. So one, you can see the fangs listed here. Notice here's a harmless, non-venomous snake. Notice here they may have some teeth, but they're not going to have the same sort of fangs as you would expect to see. We can even use things like the anal plates to tell us whether or not the snake might be venomous. And again, this is just here in the U.S., specifically here in Florida. So say, for instance, here with a rattlesnake, you'd have one, if you see the rattle, that's helpful, but maybe not, because things like copperheads and cottonmouths won't have this. But if you have a single row of anal plates, then that means it could be venomous, right? Versus a double row here would mean not so much. You may say, like, why would I ever need to look at the anal plates of a snake to know if it's venomous or not? And hopefully you're not close enough to the snake to look at the anal plates. But I'll tell you an example of this. And nowadays we'll always just say, well, just take a picture of the snake, because I don't know too many people who don't have a phone with a camera in their pocket, right? But back in the day when this was not as available, we would have patients who would bring in the snakes with them, and sometimes they'd even be decapitated. And so they would just have the body of the snake and not necessarily the head. And without the head, it's really difficult to determine, for the most part, whether it's venomous or not, right? Because a lot of the coloring may not really be all that indicative, so it can be tough to tell. And so the smartest man I've ever met, Dr. Kunisaki, who was my medical director during my fellowship, one time they had a patient in the ER who had been bit by the snake, and they didn't know if it was venomous or not. And but the patient had brought in the body of the snake, but the head was not available. And so couldn't tell, hey, do we need to give the antidote? Do we not? What do we do here? And so Dr. Kunisaki comes strolling into the ER. He's got his coffee there, and he looks at it. He takes a look at the body. He's like, non-venomous. And the attending at the ER, he's just like, how can you tell? He's like, you can tell by looking at the rows right behind the anal plate here. And the guy goes, Dr. Kunisaki, you're the only person I know that can look at a snake's ass and tell whether it's venomous or not. I always thought it was one of my favorite stories about him. But anyway, other than that, other things you can look at include the pupils. So you'll find that pit vipers have elliptical pupils here, whereas the non-venomous snakes typically will have round pupils. And then the presence of a rattle is helpful, but it may not always be present there. So he kindly asks, I heard that non-venomous has bigger head and more teeth because they need to have a better bite to grab onto food. Not necessarily a bigger head, maybe. Because if you look at the pit vipers here, they have a large triangular shaped head, so it's bigger than their neck for sure. But certainly they have those rows of teeth because they have to grab on. That'll actually become important when I talk about the eastern coral snake here in just a few moments. But in terms of the bite characteristics, you're going to find, especially if you didn't have any snake available, you had no picture, and you were looking at the actual bite itself, obviously you'd expect to see 2 fang marks, but that may not always be the case. Sometimes the fang has broken off, it hasn't regrown, so you may only see 1 mark there, and it could still be a venomous bite. Frequently, though, you're going to find snakes may have like dry bites. And so about 20 to 25% of the time, the snake doesn't actually inject any venom. Because one, it's typically not looking at you like you're its next meal, so probably doesn't want to waste all that venom. And where if it's eaten recently, then it may not want to do that as well. Are you saying rows teeth? No, I'm saying rows of teeth. It's like a row of teeth. I don't think they have any actual rows teeth unless they're in the garden recently or something like that. But sorry if my enunciation is poor today. Also, think about things like the size of the snake. So the bigger snakes mean bigger bite, more venom potentially. And then also look at the location of the bite. So this can be important because, obviously we're going to be looking at the injury itself to actually do our measurements and things like that. And I'll talk about the characteristics of the envenomation in a moment. But essentially, you'd expect to see frequently that the feet might be one spot where you see a lot of bites, especially if you're just walking around and you didn't see the snake. That's one way you see a lot of envenomations. Otherwise, it's frequently the hands because people are trying to handle the snakes. So kids, you see that in a lot of male patients, you'll see that in terms of bites on the hands. But sometimes you get some atypical places for bites. So for instance, if you have someone who's trying to take a selfie with the snake, I've seen bites on the lip, I've seen bites on the cheek and neck. Not great, right? So again, probably just leave them alone. No need to handle them. So looking at the actual envenomations themselves, you can kind of notice some things here. So one, you're going to see a lot of swelling associated with this. You're going to see progressive swelling that can progress, if it's a bite on the hand, it can progress all the way up the arm, and they can be double in size of the unaffected limb. So they can be quite significant in terms of their how much it gets expanded. You see these bullae, they can form here. You can have a lot of ecchymosis. You're going to find that the venom itself tends to be works as basically causes a coagulopathy. That's why you can see why you see so much bleeding, why you see so much ecchymosis associated with this. But a lot of swelling, a lot of ecchymosis associated with these bites here, and there's a lot of pain as well. It's quite painful bites. And so what you end up seeing is there's a lot of different antigens that are here. There's proteolytic enzymes, there's pro and anticoagulants, there's even cardiotoxins in some of them. And so directly causing tissue damage is one of the big things we see there. That's why you see so much pain. That's why you end up seeing so much swelling, and that progressive swelling is one thing we're really worried about. But it's also the systemic effects we care about as well, things like the coagulopathy. And so that'll go into the monitoring parameters we'll look at in just a few moments here. So what do we do? Or actually, the local reactions we're going to see here. So a lot of painful swelling, a lot of paresthesias that can develop potentially. You'll see all this ecchymosis and blistering, and here's a good example of that. In some cases, you may even see rhabdomyolysis, although that's quite rare. There's a snake called the canebrake rattlesnake, which we don't see too frequently, especially down here this far south in Florida, but that can be something you see occasionally. And in general, if you're considering like how toxic each of these bites are, rattlesnakes tend to be the worst, followed by the water moccasins and then the copperheads. In some places, people don't even treat copperhead bites for the most part. They just kind of work with just supportive care. In terms of systemic reactions, though, patients may have a lot of anxiety and a lot of fear because they were just bitten by a venomous snake, and there are a lot of pains associated with this as well. In addition to that, you can see, tachycardia, nausea, vomiting, just because they're so anxious and maybe kind of freaked out. Renal failure, occasionally, if you're dealing with something like rhabdomyolysis is a potential. We don't have these here in Florida, but they actually even have like neurotoxins and something like the Mojave rattlesnake you might even find out west. So depending on where you're working at, you may find different kind of flavor of snakes that are there. And then the hematologic toxicity is what we really care about as well, because we can find patients that will develop significant coagulopathy, whether that's increases in PT-INR. You can see fibrinogen decrease, platelets decrease. It can be pretty significant. And so, for the most part, one of the big questions we get at the Poison Center is like, well, do I need to treat this patient or not? And so typically, in order to evaluate for a dry bite, we'll wait about 8 to 12 hours after they show up in the ER to determine what we need to do. And things we're looking at are to see, do they have progressive swelling, which I usually consider, if it passes the joint, then I consider that progressive, like a major joint. So if there is a bite in the hand and it crosses the wrist, then I consider that progressive. If it is on the forearm, it crosses into the elbow, I consider that progressive. And then we're looking for the coagulopathy as well. Things we tell patients not to do, this is really important kind of first aid stuff, is like don't put a tourniquet on. People think, I'm going to stop the spread of the venom. What you're really doing is stopping oxygen supply to those tissues that are now dying off, and so we don't want to do that. Not only that, but patients put on tourniquets way too tight, and they end up causing all that to be released at one time, and basically can lead to some cardiovascular complications, which can be a problem. Sorry about the screaming baby in the background, but other things to consider is you don't want to cut or suck on the wound itself. You actually find that it's not really all that effective. The best thing you can do is, and I tell patients this, is the best first aid item you can have in the case of a snake bite is a set of car keys, because that can get you to the ER that much faster. At one time I told that to students, and they were like, what do you do with the car keys? Do you rub it on the wound? And I said, no, you put them in your car so you can drive. But other things to assess, tetanus status, you need to get that updated. Look for allergies in case they've maybe had bites before, or maybe reactions to antivenom previously, and then find out have they had bites in the past and what do they do about them. Mainly because usually a thing that predisposes a patient to get a snake bite is if they had a previous snake bite, because usually they had bad behavior that led to that, and so you can see your repeat customers. And then we can also help them manage their pain and anxiety. So in terms of monitoring, we're going to go ahead and do circumferential measurements. So you usually use 2 lines to mark around, say for instance, if you're marking around the arm or wherever the bite was, and you can measure where the swelling is going in terms of it getting thicker or if it's actually progressing up the arm itself. I'm sorry if you couldn't see that. In terms of hematologic monitoring, we're doing platelets, PT-INR, PTT, and fibrinogen. We typically monitor this initially and then every 6 hours to see how that's progressing. For the most part, and you'll see these patients will be so swollen, you're going to think, oh man, they're going to have compartment syndrome. And they really aren't. What they really need is the antivenom. And so some places, they consider doing things like fasciotomy and digitotomies, but we typically don't recommend those unless absolutely recommended or absolutely necessary. In a lot of cases, it mainly can be kind of disfiguring. And rarely do we really need blood products. Here's an example of this, this would look like if they actually did fasciotomy. And again, this is going to be pretty scarring for the patient. So the best thing we can do is just give them more antivenom. So what do we do? So the main one we use now, and there's actually a second product, but I'm mainly going to talk about this one here, is going to be Crofab, which is our antivenom. And basically this is a sheep-derived product here that is antibodies against these 4 snakes. And you'll notice that even though it doesn't cover all the snakes that are here in Florida, they do have a lot of cross-reactivity, and so you'll find they can work for the ones we have here. So, and what we're going to give them for is if they're having progressive swelling, if they're having coagulopathy, or if they're having any kind of hemodynamic compromise, that's when we're going to go ahead and give it for those patients there. And so you can look here at the dosing, but basically based on the how symptomatic the patients are. We give between 4 and 6 vials, and we look to see if they have any kind of reactions to it, any kind of allergy, and then we go ahead and administer the full amount over about an hour or so. And then we actually give them some maintenance doses afterwards to make sure they don't have any kind of recurrence of symptoms like swelling or coagulopathy. And keep in mind, it doesn't reverse the swelling, but it just prevents it from getting worse. And so you may find it may take weeks before patients will have full resolution of that swelling there. So it's an important thing to note as well. And then we'll monitor them about 24 hours past the last maintenance dose and see how they respond. Make sure they don't have any delayed coagulopathies. And if they don't, then they're usually good to go. We can send them on their way home. So here's an example of what this looks like. This is actually the newest one called Anavip. And so looking at CroFab, I've talked about antibodies before, and we know that the full antibody here, the whole IgG, this can be problematic from a lot of standpoints, mainly due to allergy, right? So if this was the original antivenoms we had were actually equine sourced, and so these would actually cause pretty significant anaphylaxis. And we'll look at some equine antibodies a little bit later on. But when we use CroFab, this is actually just the Fab version of the molecule. Basically cut off the FAB portion of the antibody, and this is what we use for CroFab. The problem with this is that it gets cleared from the body pretty quickly, and so this is why you end up seeing like delayed coagulopathies and whatnot. The newest one we have is called the Fab2 fragment, and so you can see here that it's a bigger molecule, it lasts longer, and some people feel it's better for preventing recurrent coagulopathies. But so if you ever see Anavip, that's the new product, and CroFab is kind of the old one that we still use pretty commonly. So, again, as I mentioned, the swelling is not going to be reversed specifically with using CroFab, but in case patients sometimes will have anaphylaxis, oftentimes you just have to treat through it. So give them steroids, give them Benadryl, maybe epi if need be. We typically will tell patients to make sure they don't participate in any kind of like contact sports or anything like that for a couple of weeks after the bite, because they could see bleeding and bruising or propensity for that is one thing to note. And then the same thing goes for like elective procedures and whatnot. Maybe they may be more prone to bleeding in those cases there. In terms of the serum sickness, this is something that is sort of a delayed reaction your body has to these foreign antibodies. It kind of presents like flu-like symptoms. Normally we just treat with some Tylenol, and that's usually good enough for most cases there. So anyway, I think I'm going to cut it off there. I think I've talked long enough, and my children obviously do not want me to go any further, as you can tell by their screaming. So do you have any questions that I can answer right now before I go and cut this off? And then we'll finish up tomorrow, and then our review will be on Thursday. All right, well, I don't see any questions popping up here. I'm assuming the delay is not too bad. Oh, how does iron cause hypotension? So that one's an interesting one. Essentially what you're going to find is that with iron, it kind of goes through a couple of different stages. But one thing that it can do in high doses is it can actually uncouple oxidative phosphorylation. So the normal process that your mitochondria use to form ATP, it basically can stop that from occurring. So your body kind of switches from aerobic to anaerobic metabolism. And so when that happens, even though the patient is being adequately oxygenated, the cells just can't use it. And so that ends up causing a very significant lactic acidosis that can develop there. And as your body becomes more acidotic, those proteins tend to denature, and they can't really respond as well to things like norepi or epinephrine. And so that can lead them to have a difficult time responding to your pressors and whatnot. And so generally that's how you see the hypotension develop there. They kind of get this leaky sort of almost like a septic kind of thing there, where you see this a lot of inflammation happening, and they can kind of leak fluids into the intravascular space. And so that's another thing as well, is you got to make sure they're staying well hydrated, give them lots of fluids and pressors to help respond to that. So I'm not going to get too much into iron any further. I can do a whole class just on tox stuff, but that's how you would end up seeing that. See, I don't see anything on the sticky board. I don't have any other questions here. So if anything comes up, though, we can definitely talk about it tomorrow. And I will see you all then. Thanks so much for joining me again.